They were largely positive. In addition to that, the strategy and action plan was being presented at a number of boards, so the Health Scrutiny and EAP. Again, feedback was that it was largely positive, and most attendees had either seen that as part of the consultation processes or have been given the opportunity to contribute to that action plan and strategy. The report that I presented today, again, is sort of a process of bringing that back to board. But the suggestion is, because the survey has not been analysed yet, that actually that part comes back with an update in about 6 months, because each of those elements of that action plan will be coming anyway to board, some of which are coming today with myself and with Patsy.
Thank you very much. Any questions or comments from anybody on the overall strategy or the items that Lee's spoken about? No? Everyone happy with that? I think it's been, through a lot of different stages, and in fact at the executive last week it was very well received. People were quite content with it. Somebody did comment that it didn't cover every area of health, which it was never intended to. It's highlighting specific areas, and so the areas it's highlighting, I think, going into depth in them rather than doing a scattergun over everything you could possibly do is much better. So thank you very much for that. And so we'll go on to the next part of that item, which is Helen is going to tell us about, and then hand over to Patsy as well.
So thank you, Councillor Mercer. So in terms of the children and young people theme, you'll recall that last year we brought our outline. We agreed that we were going to focus on family healthy weight and bring back an action plan that detailed some of how we would meet our objectives. We weren't able to bring it as expected at the last board, so we're now going to talk through our progress to date with particular references to those 4 themes, and I'm going to pass over to Patsy to outline that for you.
Hello, thank you. So yes, as Helena said, we've been working on 4 themes for the health and wellbeing strategy, the children's element of it. And as you'll see, starting on page 101, it lists the 4 themes, what is there. So the first one of those 4 themes is exploring different ways of how we can develop interventions for our early years and children. So what we have been doing, you'll see, if I go down to page 105, you'll see progress against Objective 1. And so the objective was to think about how can we bring in interventions into North Northants for our children and early years settings where we've got overweight and obese children. So what we've been doing is exploring the Henry programme. So we've met with the national lead for the Henry programme just to explore if that's something that we could bring to North Northants. We've also met with colleagues in different authorities, namely Derbyshire, because they had a programme called the Children's Choice, which looked really interesting. So we explored that in a bit more detail. We also have our Healthy Schools that are working on a Healthy Eating Ambassadors programme, which is due to be rolled out soon, and that's going to be with our 30 primary schools. And then we are looking at, as it says there, developing a draft healthy living offer. So using the information that we've gathered in our bit of research with in those other areas, it's not been finalised yet, but what we've come to realise that it's not a one size isn't going to fit all, and one of the key things we have to think about is the kind of the language we use when we're talking about healthy weight, and how do we really get that message across without reinforcing the stigma that goes alongside of that. So we are going to be looking at something called health at every size. So thinking about how do we retain people, help people to be healthy, regardless of the size they are. But we need to understand about the other things that come into play when we're addressing, healthy weight. So I'll go into the next bit as we come along. So the next thing that we're going to do, so our second objective is around a whole systems approach. And so that's working with different partners who contribute to healthy weight. So, and that kind of looks at some of the wider determinants that impact on healthy eating, and for people to be able to afford to eat well, to afford to be in a place where they can have access to cooking facilities and all those different kind of things that contribute to people's ability to eat well. So we had planned to do a whole systems mapping event on the 1st of May, but clearly that's election day, so we need to rethink that. So we're just in the process of setting another date. And also we are linking into the ICB Leader Healthy Weight steering group, and that's looking at health at all ages. So we are feeding into that. And as part of the CYP Transformation Partnership, we have the Best Start in Life, which we're also leading on. So it's trying to ensure that everything is marrying up together, that things are not going off in different tangents and isolation. So that's objective 2. Objective 3 is the one where we recognise there's a synergy between oral health and healthy weight and obesity. So that work stream is been developed through our Northamptonshire Oral Health Alliance. And the work that we're doing there is around how do we continue to promote consistent messages around oral health for the system. So we've reviewed some of the materials that are out there. The Alliance has agreed what the messages are we're going to use, and that's the information that's going to be communicated across system partners. We've also initiated an early years work stream, and that's going to be looking at developing healthy eating, nutrition policies and guidance for early year settings. That's something we're really keen to do to support our early year settings, to be able to have that information, knowledge, and then the confidence to have those conversations around that. And then we'll continue with the infant feeding strategy as well, which that really focuses on how do we support parents when they're moving on to solids and the kind of things that they should be cooking, and how to cook and how to feed their children. And another element of that strand, objective 3, and we've just heard this week that we've got some additional money in to do some work around supervised toothbrushing. So again, that's going to be more money coming into Northants to help with looking after children's teeth in the early years, and so that's for our age group 3 to 4 year olds. And then the last one is objective number 4, which is keeping active. Again, so this is we've thinking about how do we, because things go hand in hand, don't they? So we're thinking about how do we work with our system partners involved in physical activity. So we've set up the work stream for that objective, and that first meeting was held last week just to think about how do we do this. And this has been led by NSport, is the officer strategic lead for physical activities leading on that one. But it was a really useful meeting because it really highlighted how much money is going into education through different strands. We've got leisure services, we've got NSport themselves, we've got public health, all different people are contributing money to physical activity in education. What we need to do is really kind of understand that, map it out properly, and then see how we can work together to make sure we're getting the best use of that and make sure we're not having duplication. And then we need to think about young people who are not in education as well, because they still need access to these kind of things. So there's a working group set up for that, and I'm sure there's going to be subgroups of that working group because it's quite a wide remit that it's covered. So they're the kind of the 4 strands, and that's where we're up to date. There's a lot more work to do, but just to give you a flavour of what's happening so far.
Thank you very much. Anyone like to comment or any questions or anything? I'd just like to say I visited a school, sorry, Jane, I'll come to you in a sec, that was doing the healthy eating competition, or healthy schools competition, and it was absolutely delightful. Helen, I went there. They were so enthusiastic, and I thought this is the way to do it. Get in young, the activity, the eating. They were going. They wanted to. They'd got the bronze, and they were going for the gold. And the member of staff there was hoping that there'd be a platinum set up at some point so that they could go for that as well. So enthusiastic, and it was really sort of the heart of all of their education. So it was really refreshing. Jane, sorry. See.
Thank you, Chair. I haven't got a name tag today. If anyone doesn't know me, I'm Jane Bethay. I'm Director of Public Health, Communities and Leisure. So I just wanted to remind the board, actually, of why this is a slightly different strategy, why we're doing a slightly different approach. So what I hope the board have seen from Patsy's and Helen's presentation is action. So what we didn't want is a strategy that sat on the shelf. We wanted a strategy that said, where do we need to do extra work and what resource we put behind that to make sure we actually deliver. And so I think what you've described there, Patsy, in a very short period of time is actually a number of new areas of work and some existing ones that have been bolstered. And I think that's exactly what we wanted as a board, actually. We wanted something that was action-focused. I really like the close working with the children's team, for example, around the family hubs and integration. That's something else we need to achieve as a system, I think, going forward, have really good integration, because that's where the major benefits will be. But I just hope that when we go through this process throughout the year, you'll be coming back later in the year to say, and these are the outcomes we're having with the work that we're doing. This is what's working, this is what we're going to roll out, this is what isn't working, what we might stop, because the whole point of this strategy is it's iterative, it's action focused, and it's about getting the right outcomes for the population. Thank you.
Yeah, Helen.
What was implicit in what Patsy and Lee were saying, but is throughout the strategy, is the focus on health inequalities. And we don't always have the data we need to ensure that everybody is accessing the physical activity, the movement opportunities they might. So we've got real focus there. We're also ensuring we're really cross-cutting with existing work. So the physical activity theme of the Health and Wellbeing Board strategy, but also the, I'm now going blank on the name, Keeping Active strategy. I always doubt myself whether there's a name. To make sure that we're just not doing the work twice. And the other part of that is thinking about the food offer and access to food. And again, this is a conversation we've had this week. Because there is, for some families, a knowledge aspect, but there is also the pressure on family budgets, the challenge in using food banks and what the food offer might be, ensuring access to fresh food and thinking about low-cost ways of eating. And that, the conversation we had yesterday, is linking that into the lapse part of it. So we think we're stitching the system together as well as we can at this stage. But if colleagues have, another idea or another opportunity or an area where they would like to point us towards, then we're really keen to do that.
Thank you. The one other strand that I just wanted to pick up on was the Grow, Cook, Eat project, which I haven't seen much written about it, but I know it's going on, and it's it absolutely helping with this strategy. So that's public health funded, and I know that's run by Northamptonshire. But that projects like that are all going to help the overall strategy. So that's good. But I'd just also like to bring up I know there was some discussion about fast food outlets and how close they are to educational establishments, and it's something that really needs to be talked to with the planning policy people about what can be done. So I don't know if you've made any progress on that. But
So when Patsy talked about doing that system map, Part of that is to understand all the different impacts there are. So when we sometimes think about the obesogenic environment, we think about what's everything around us that impacts, in this case for a family, around family healthy weight. So there's a new national indicator around hot food density. What that says is we're broadly in line with the England average. But we know that there will be differences in different parts of North Northants, because it's a North Northants level. So the meeting with the new colleagues working with East Northants and Corby Lap yesterday was thinking about how can we really bring that to life on the ground. What might we understand about hot food takeaways, densities within smaller geographies and what the impact is, but also to really understand from communities what they see as their assets and their challenges. And the councillor who is unable to be with us today has done some interesting work, himself around fast food access. So that's definitely on the list. It's also the sense of safety of feeling whether people can be physically active. Are families confident for, children to go to the park in the way, some of us remember as children, our parents were happy for us to do that. When we think about adults, do they feel that they can go for a run at night? And sometimes it's not whether it's actual crime, it's that fear of crime. So as we build that system map, we should understand all of it. And as always, it's really important that residents, children, young people and families tell us what's important to them, because that will inform our interventions.
Thank you. And at 4.6, it says the percentage of children that are overweight, 36.9. That is huge. But I know there are differences, as you say, because I've seen on the laps with the different layout, different percentages for each area. So, it's obviously targeting where the main problems are, so that it's not a scattergun approach. It's really targeted at specific areas.
It'll be a graduated approach. As often we would in public health. So some of the offer will be primary prevention. So that'll be, information and support available to everybody. And some of it may be, where do we need more targeted support? And broadly, although not exclusively, childhood obesity follows deprivation. But the paper I first presented to you perhaps gave us a picture that we wouldn't have expected. It's not as graduated as you would see around something like smoking, for example. So we need to understand at smaller geographies what the impact is. And the paper talks about National Childhood Measurement Programme, and we do have that at school level. So we have it pooled 3 years for schools. So that information is made available to schools. So that's targeting at children who are in school. But then the broader community and understand those aspects. We don't have the same, readily accessible data sources. So that's where local intelligence becomes really important.
Thank you. Anyone else who'd like to make any comments or has any extra information to add? Well, thank you very much, and keep up the good work. It's certainly, obviously, I'm sure the board would like to see the outcomes of this. It's moving, forward, and see how hopefully those figures will improve on the. So I think that we need to then move on to the mental health and wellbeing key priority. No, don't we? Doing that on Lee, isn't it? Yeah. Sorry. Jane, are you? Oh, sorry. Helen, did you want to come back?
I thought we were coming to me in Family Hub, so I think it might be my confusion, is it?
Go first if you
No, you go next.
Sorry, Chair, just on the agenda, going to the agenda, it looks like it says Health and Wellbeing Strategy Overview, Mental Health and Children, Young People's Update, including an overview of early help, family hubs and integration. I would suggest, considering this was an item on children's, it might be useful to move on to the family hubs before mental health.
Yeah, absolutely, okay. Yeah. Yes,
thank you. So that's me, and Lorraine will chip in. We might do a bit of a double act. So some contacts for colleagues. So one of Public Health's mandated functions is to commission services for 0 to 5s, principally the Healthy Child Programme. We've recommissioned across the 0 to 19 and in a different approach. We've taken an innovative approach. So for 0 to 11s, which will be the focus of what I'm showing here, is fully integrating that 0 to 11 service with family hubs. For 11 to 19s, that the provider will be NHFT, but in partnership with REACH, which are a collective of third sector organisations who've got experience across a range of things, including mental health. So a refresh in terms of people's minds in terms of family hubs. So it's a joint programme between the Department of Education, the Department of Health and Social Care, and that means it has joint leads here in the authority. So Jane in terms of public health and Charisse in terms of children. And in terms of developing this, we're particularly thinking about the Start for Life themes. So that's the bit that nationally comes down to us and we decide locally what our direction is. So things like infant feeding, perinatal and infant mental health, the home learning environment, and speech, language and communication. And without working in public health, you'd easily see that they're also public health priorities. So what that gives us the opportunity to do is think, how do we implement some of that work locally? So absolutely led from family hubs, but public health have been really integral to developing. So that provided an opportunity to think further around integration because the test and learn pilots have given us the opportunity to, in a sense, learn in real time. So what works around infant feeding? And often people would say the system was confusing, it was hard to know what point to come in. So how do we have that open access? So there's something called an Anya app. But for people who need more support, what might the support look like and who is best placed to provide it? And the app's interesting. People access it in the middle of the night. And, you know, any of you who've had babies who you struggle to settle in the middle of the night, know that is the time. You know, you want to access something. And a self-help approach, a digital approach, is often the best way to do it. But for some of us, we might need more support. And what happens through that work is, well, actually, the system is a bit disconnected. It's confusing. So what our integration gives us the opportunity to do is have, you know, a single point through the digital front door, and it would be remiss of me to say that the Family Hub's website, Family Hub's digital front door, has been shortlisted for an LGC award. But how do we come through that into that Public Health Commission service, so the offer provided by NHFT?
थोड़ा सा ट्विस्ट प्लान में शाम का डिनर गौरी just mentioned कि उसका
Sorry.
Okay. I thought somebody was coming in. I think it was just a microphone.
Sorry.
So I'm going to start my bit about, or partway through my infant feeding again, just get my brain straight. So alongside some of the digital offer, there's been a real investment in training, in developing the workforce, and in a sense, the legacy of some of the family hubs is in the people. Public health and family hubs, it's about open access, it's about universal offer, but a universal plus, or we might call that early help. So if I'm that person who perhaps needs a bit more advice and support around breastfeeding, you know, perhaps I'm having a challenge around my mental health, perhaps I'm, and all of these, you know, apply to me. I'm having a child who doesn't sleep, perhaps I'm not sure about behaviour and want some parenting support. I don't want to try and decide which door to go through. I want to go through something where I get the right support from the right person without having to think about some of those professional barriers. And that's what this integration will do. It will mean that a family has access to multi-professionals who work effectively together, some of the time in a physical space, so in a family hub, but also in terms of that virtual and that wraparound. And we've called our service Best Start in Life, and it is about every family and every child having the opportunity to thrive. Excuse me. And we might think about being ready for school, we might think about speech, language and communication development, a 2.5-year review. But also it's very much around the family. So the family's capacity to be able to provide care and support. And that might, because we can't see, as we all know, children in isolation. So it might be fixed term programs of support around behaviour, for example, or sleep. So alongside the integration, there's a public health investment into family hubs. And the early help workers will be providing some of that. And in other areas, in other services, that would be a core part of the health visiting service. But what we're having is a multi-professional approach. So it's the person with the skills and the training who's providing it, rather than relying on a particular set of professionals. Increasing skills and confidence of parents and carers really comes back to some of the context that Patsy was giving. It comes back to that family resilience. And when Lorraine talks to us around the item around the SEND strategy, this is the really early bit of the pathway. There may be some families for whom, a digital offer puts them on the right path. It may be for some families that a short programme is the right. And it may be that we start to identify SEND needs earlier, and that means that families will receive the right support. And the approach is less, let's escalate, and more, let's move across. And when we had a peer visit from North Yorkshire, we were very taken by that language, because that's very acceptable families. It's not, your needs are escalating, we're moving you to a different service. It's a thing about who best meets needs. I'm just checking I haven't missed anything. The two areas mutually enhance each other, and it will provide greater access and a range of access. And unsurprisingly, we're really talking about evidence-based programs. So we might seek to grow the evidence base locally, but there are strong evidence for a number of programs. So for example, the speech and language toolkit is welcome. So it's something that we would know. What have I missed, Lorraine? So just coming in terms of the family hubs, and we'll take questions together.
Okay, thank you. Hello. I just, you haven't really missed anything. That was really good, but I did want to say, I do want our members and partners to know that I'm hugely proud of the Family Hub team and the resources that are wrapped around our family hubs. Having engaged with them over the last 6 weeks, they are exceptional people, and they've really connected with families, children and young people really well, and I think that's a huge celebration of the hubs that you've got today for our children and families. So I do want to say that. I think what I was going to update you on is more about the process as well, because obviously we have now received an injection of further resources and money into the Family Hubs programme. And at the moment we are in that process of developing with our strategic partners what the year 4 high priorities and the spend will be. Obviously, we have to follow the conditions and criterias of the Start for Life programme and the spend within that arrangement. But it does give us a bit of a stock take and an opportunity to actually work with our strategic commissioning partners also to say, actually, how can our family hubs be more sustainable in the future? And part of that is how can we look at early help and inclusion in our SEND community, as well as our Start for Life offer, which is hugely important to us. And we would want to be encouraging through that strategic commissioning programme what our investors actually look like into our family hubs. So that actually we're growing family hubs that are responsive to our communities and what that means for them. And actually we can start to see, as we have seen in fairness, improved health and well-being, because that is fundamentally the driver around good family hubs. In terms of the process, we have the Department of Education, which myself and Belinda, who's with me today, we have met with, and we have a process now of engaging our financial delivery plan by the 8th of April. After April, we have a 12-week period of actually doing co-design with our strategic partners. And it's that co-design work where we can take a stock take into what is working well, what is not necessarily working too well, and how do we want to improve over that longer term plan. that will result in a family hub and early help strategy and plan that is much longer than the programme, so that we can start to build that sustainability. I hope that helps, and I hope I haven't missed anything. I haven't spoken to a mic for a long time.
Thank you very much. It's a hugely exciting programme, and I'm really looking forward to seeing the results and the outcomes from it, because it certainly seems to tick all the boxes, and and certainly the digital hub, which is also, I've seen a demonstration of it. I haven't actually tried to use it myself, but I haven't got any young children I'm trying to feed. So, it really is worth looking at. Any other comments? Oh, David.
Thank you, Chair. Really good work going on there. I guess the main question, bearing in mind the temporary nature of some of the funding, is how are we going to evaluate the approach and make the case for ongoing funding moving forward?
So there's I think it's out at the moment for an evaluation partner. So some of that will be process evaluation. Some of the evaluation in perhaps a softer lens is sort of in time. So if we think about the infant feeding, there was a particular organisation where there was a test and learn and really wasn't delivering, so that work has ceased. Some of the work around perinatal mental health has already come into the service specification in terms of the 0-11 contract. And if we think about some of the family hubs and the physical spaces in family hubs, you'll recall a paper coming through Transformation and Efficiency Board and also through CLT that secured funding for some of that sort of nuts and bolts of it. And Lorraine and Belinda will have most heard me say that we haven't necessarily had some of the architecture to build on that other areas do, and so our starting point is different, but certainly the legacy today is absolutely is in the people, it's in the training, it's bringing the partnerships together. Where the system is under pressure financially, it's harder to have these conversations than it would otherwise be. So I think we are still in the art of the possible if we're looking for funding across the partnership.
Lorraine, did you want to?
Yeah. So I think another angle to that, bringing strategic commissioning in this as well, because obviously we're part of the regional and national network now, and we are in those conversations with other councils who actually have started to exit, by the way, from the national programme, because actually they've moved into a model of self-sustainability investors. So just to give a bit of assurance to parties in the room, I am in the conversations with those councils. Without doubt, it takes organisations and business to go, we have got something special here in Northants that we want you to get excited about, and we want you to come to the table as investors of change around the areas of priority that are important to our children, young people in those communities. So we're not there yet, but I have to say from the national programme and the conversations I've just had with the Department of Education, they are out there, and part of good strategic commissioning is looking to those comparisons and seeing how we can draw those models into Northants to actually build that into our programme so it does become a sustainable offer. I don't mind sharing with parties, I didn't realise that there's quite a considerable number of councils that have now today got a sustainable family hubs community model. So it's building that learning, and through the testing that actually Helen said, we will get to that place, and it will look a certain way for our local people. So that's really important. I hope that answers some of that.
Okay, thank you, Jane.
Thank you. I just wanted to make a broader point, actually. I think one of the things that challenges us as a population in North Northants is school readiness. So how ready a child is to start school and to make the most of that is a fundamental thing. And that leads on to a whole range of different things. Children who aren't school ready are then less likely to do well at school academically. They're less likely to reach a whole range of different potentials. And I think for us, if we think about the wider implications of this work, I think we are setting young people up and families up for a far brighter future by taking this particular approach. The other thing I wanted to quickly take an opportunity to do is to thank the people for the amount of work that's gone into this programme. It's been phenomenal. And I also wanted to thank Dave NHFT for coming on that journey with us. So people will know that NHFT are our provider of 0 to 19 services from a public health perspective, and the willingness of NHFT to come on this integrated journey, I think, has been a real game changer for us. I think it's a really good example of integrated working. It's a really good example of putting families and children at the heart of what we do. And I think as that builds and develops going forward, we'll see massive benefits from it.
Prince.
Yeah, thank you, Chair. Just a couple of things. I think the Family Hub is really a positive thing. Regarding the physical spaces that we've mentioned, I'm aware that it's not all over, certain places. I guess my question to that is whether that is being looked at and whether we're going to have physical presence in places where we can have family hubs. And the second thing I want to mention here, Chair, is the online family hub. One thing I've heard was that some parents struggle to kind of pick up some information when they search for it, and that they don't actually get the relevant information that they require, and that frustrates them as well. And whether that is something that is being looked at. And I guess my final point on that is, with regards to the labs, I know they also want some integration into that space of a family hub, digital front door. What is that looking like at the moment? Is there anything being agreed on to see whether we can have that coordinated and well orchestrated, front door for all these areas? Thank you.
Thank you.
So let me just check I've understood your question in relation to spaces. Is it around the family hubs that are open or will open, or is it around there being more spaces in different communities?
In terms of the communities, whether we have strategically located those physical places where we can, have those family hubs for parents to engage, especially if they cannot access online. And we know that some parents are not digitally, literate enough to kind of use the online version. So that is what the question is.
So there are spaces that are open. There are spaces that are coming on board, but there will not be spaces that will be accessible to everybody in every area of North Northants, which is why the partnership with NHFT, for example, is important, because that gives us a bigger estate, alongside thinking, particularly if we think about young people rather than thinking about young children, where are the spaces that people want to be? But there is a very valid question about our thinking collectively about our broader estate and how we use it, and how we enhance our community spaces and use them effectively. So I agree there's something we could do some more on. The interesting thing about the digital front door is it's got an iterative learning part of it. So Councillor Mercer and I were at scrutiny, and we'd used the language weaning, which I'm afraid tells you that we're of a certain age. That's not the language that's now used. And another councillor colleague said, but it doesn't say weaning. That's because if you're a younger parent, you talk about moving on to solids. But as soon as a term like that doesn't work for somebody, and the Family Hubs team know about it, that could be changed. So it might be you're thinking about specific language. In terms of accessibility, it's the most accessible front door I've ever used, both in terms of different languages, being able to change the size of your font, the colour of your screen, having it read to you. So what I'd say is, if you do have that feedback, it'd be really helpful to have some specifics so we can feed that into the process. It's a colleague called Maria who does a lot of that digital work, and I'm happy for that to come through. Prince, I'm happy for that to come through me, if that's helpful, to make sure that we continue to learn. And then in terms of will we ever have one digital front door and will we bring the lapse in, I think we aspire to have one digital front door. I wouldn't say I'm confident we'll do it across everything. The other thing that is mentioned in Patsy's part of the paper is iDiscover, which is one of NHFT's, advice for, children, young people and parents. In some ways, feedback is that Family Hubs has a young family, has a child, flavour to it rather than young people. So the single front door, I'm not so sure. Lorraine, is there anything you want to add to any of that?
I mean, I think in terms of the digital front door, there's definitely some more work to do around the correlation and synergy with single point of contact, single point of access. I will agree that having seen a lot in other areas, this is a very good one, and this is a strong, I think it's on about 97% accessibility, so that's in the very high quartile of accessibility, so that's really, really strong. My own view of it is people just aren't like that, parents, children, families, and you're never going to be able to create something that's going to be fully quite there. You can always enhance and make the changes, but you're always going to have to produce something that is not within that digital space. There's definitely some work we would like to do around AI as well, and self-serving. So that's, that whole place where you can type in a question and it will give you the automated answer that you'll need. There's lots of other councils actually exploring that now in that space. There's obviously a sense of pride by the team because they have been shortlisted by the national awards, and that is a huge deal because obviously hundreds of organisations get involved in that. And whilst you may not win the big prize, just being shortlisted is the bee's knees, as we say in Yorkshire. Sorry, everyone. So that's really, really good. But there is work to do, and I think as long as we can continue with that open dialogue with our families and our children and young people, which we do, and we can keep amending and changing the product, how that works, then I think we'll get in a really good place. But I would never think it covers everything. It simply can't. I always kind of make sure people understand that.
Thank you very much. I think, do we need to move on perhaps to the mental health item on this particular agenda, if that's all right? Okay.
Obviously the mental health agenda is coming because it is a key priority of the Health and Wellbeing Board strategy. The aim of the strategy was to seek and reduce inequalities in access, outcome and experience by refining and strengthening the work around reducing self-harm and suicide prevention. And I think it's worth talking about the next one, which is around that cross-working. So one of the slides that I'll draw your attention to, I think it's 93 in the pack, is about the spread of population health around good mental health. So looking at this from a broader perspective, and I think that this is where this strategy is aiming, that we've got a lot of cross-working within this, that there is an aim to not only look at the serious mental illness and the hospitals and the acute end of mental health, but also about population mental health and our whole population experiencing good mental health. So one of the things that our colleagues here talked about earlier was around how we cross-work with our children's agenda and those preventative things that we put in around wider determinants and the synergies that we have across those. So a lot of what we're talking about in these approaches are not just about those interventions which, for instance, are dealing with an acute crisis, but we're also looking at that prevention level. We're looking across those synergies with our healthy eating, with physical exercise, of the things that we know promote good mental health. So also around our planning, our healthy spaces, and how we make Northamptonshire a healthy place to live. So we're looking not just at our access to healthcare, but also how we build those spaces so that we do have good access to those healthcare systems. And part of our leisure team puts into that. Two specific ones that we've been talking about are, one of them is an objective within this strategy, which is around people who experience serious mental illness that we know that there's a higher prevalence of smoking and therefore a higher prevalence of smoking-related illness. So there is a specific targeted piece of work within our stop smoking services or smoking cessation service, which is aimed at targeting that particular population. Alongside that, there's some work within the pillars, which I'll come on to in a moment, which is talking about those general health outcomes for people with serious mental illness. So we're looking at it from a very broad spectrum of our whole population, right to a small targeted population of people who experience serious mental health and self-harm. So I think I talked about the pillar, which I think is on the next slide, which is slide 94, if I'm in the right place. I put that in as an example of how the mental health agenda is structured across North Northamptonshire and West Northamptonshire. So it's a very much a partnership approach. And I think that this diagram, which I have immediately lost and now found, which is 94, just gives you an idea of the complexity of how mental health and good mental health is structured across our systems. So whilst there's an overarching executive group, which is mainly strategically focused, there is also a steering group that sits under that, which acts as the conduit between both of those executive steering group, executive strategic group, and the pillars that actually deliver on this action plan. It's split into different sections, which I think neatly fits in across that whole population approach, that there is a particular emphasis on the acute and hospital end, the tier 3, but also there's a prevention pillar, which of public health are very much leading on and are the clinical experts within that. But there's also the learning disability and autism transformation pillar. All of these add into that reduction of inequalities across the system. And within each of those strands, there's also specific targeted groups, which are task and finish groups. I think I brought that not necessarily to explain the whole system to you, but also to mainly look at how we're doing that across a whole system and across the whole partnership. So whilst we're looking at specific elements within this strategy, those are borne out within different aspects of mental health across the system. In terms of specifics of what we're doing, there is a whole strand of action plan within each of those pillars. So each of those has partner actions, which again build into this picture, the overarching picture of how we reduce inequalities across the system, within that wider determinants, but also within that acute end of our system. I'm not going to go into what we're actually doing because I think it's in the body of the report. So there's a whole level of activity of funding streams which are managed through these pillars, which also look at how we're working with people with serious mental illness, but also across that children's agenda, and then into those reducing inequalities across the whole system, whether that be at population level or whether that's in the small percentage of people that require intervention. So I'm going to open it up for questions.
Thank you very much. Did you want to say something?
Well, other than to thank Lee for the thought and the work, and obviously we've got quite a strong collaborative now in place for mental health across across the overall Shire, but also in the 2 local authority areas. I guess 2 things. One is the data now is beginning to really consolidate on children and young people's emotional and mental health. The Royal College of Psych have got a good paper in development outlining some of the need they're seeing. So a 9% kind of prevalence rate to, you know, significant numbers, you know, 1 in 4 numbers of young people with a diagnosable mental health problem. That's really, really significant. So that's helpful. So the intersection with CYP bit for this board, I think, is important because that is the place we could make a real, measurable, tangible change to the curve of need that is currently forecast post-COVID. And indeed, the data is now suggesting that goes back to 2013 in terms of the post-austerity impact for children, young people and their families. So that is interesting and be helpful to kind of focus on that in due course. The second thing I think for this board is the impact on physical well-being. So the health check numbers for this county compared to the region, I think we're probably up around the top in terms of the number of health checks that we're conducting for people with a serious mental illness. And that again is a real curve inverter, because the number of people who die 20 to 15 years earlier, as outlined in the paper, that will be mitigated by those health checks. So that is a significant contribution. The more we see, the better chance we have to reducing that metric. So again, I just asked the board to kind of focus potentially on those two areas as where the buttress of the strategy comes together with mental health, and we see the intersection of the different components. Thanks.
Thank you. Any other comments or questions? Okay.
Oh, sorry, Chair.
Oh, yes, sorry. Please.
Yeah, just a quick one. Chair, I can see some kind of intersectionality within the mental health of the children, and then the grow and cook. There is that kind of cross, relationship in there. Just a couple of things I mentioned in our previous meeting, and I think Jim might remember in addressing that. If the team, partners are on board on that, what we suggesting as part of the solution is where you have families, through some of our research, who are actually not having more culturally appropriate food because they are not in that place to kind of engage with that. We do. So a typical example was an Indian lady who called in and said she wanted to go and buy some spices, and she hasn't got the means to do that, so she can cook for the family to eat. What we are proposing is a way to mitigate some of these things, where we have a platform of all small local shops on the platform and corner shops on the platform, where families that are going through, just as we give out the vouchers for them to go and get stuff from Lidl and things like that, they can actually go to those corner shops and redeem them and have some, culturally appropriate, healthy food as well that they can cook at home. So that's something that we are looking forward to working on as part of helping mitigate some of these inequalities and also bridging the gap for some of these families. So it's something that I would like to have further discussion on, if that's okay. Thank you, Chair.
Thank you. Yeah, Lorraine.
I really appreciate the focus on mental wellness for early help and prevention for our children, and I just wanted to support what David said around. I've been supporting the educational psychology team around their work over the next 12 months, and obviously the increase we're seeing in our school settings and our community around mental wellness of our young people is concerning, and it does link in with some of those national trends that we're seeing, especially of some of those young people that were actually born in the COVID period and coming out of the COVID period. And I know it's always hard, not that I'm a public health expert, but it's always hard to get the trajectories on some of this information. But without doubt, Royal College of Psychology and educational psychology professionals are saying that there really is a curve, there is a trend, there is distinctly things different. And I think what was very pleasing about this strategy, Lee, and the approach was that I like the fact it takes a very rounded view, because there's no way you can support and deal with mental health in isolation. As we know, it's got to be triangulated well. It's got to talk about good food, good living, good life, good access to health. It's got to wrap around those things and also remove the stigma. So I was really pleased to see that in the strategy.
Yeah, as you say, everything's connected with it's the healthy eating, healthy living, active life, etc. They all link up, the financial resilience. But to focus on these individual ones so specifically is really a nice way of doing it, so that you're actually drilling down into it. So, okay. So if that's sorry. Jane.
I just wanted to, I have to always make a comment it seems, but I just wanted to say one thing which sort of links to what Dave said around severe mental illness and health checks and the importance of smoking cessation, and how we have to link all of these work streams have been developed because the natural linkage is there. When it comes to that enormous gap in life expectancy for people with a serious mental illness, yes, diagnostic overshadowing, we know that there are some drugs particularly that give people essential obesity, but smoking is still a massive driving factor for why so many people with a serious mental illness die way before they should do. So we've got a real opportunity here. And also having Dave, you know, as NHFT, being an executive sponsor of that work, I'm executive sponsor of the smoking work, gives us a bit more ability, I think, to do that work jointly. So I'm hoping that we see real benefits to that.
Thank you. It's interested to see, you know, the outcomes of this, and hope we improve the mental health of our young people. Next item on the agenda is an update, and Lorraine is going to give us an update on SEND. That's right.
Thank you. I don't know why I keep wanting to lean forward to the mic, but hopefully everybody can hear me. So in children services, we've continued to work really proactively on our SEND delivery plan. And there's lots of work areas within that I'll give you a little bit of an update on. In terms of our Department of Education monitoring visit, obviously we're aiming for, well, they are aiming for May. So we've got lots of work to do from now till then to make sure that our delivery plan is in a better place. And we're very confident about that. So some of the work we've been doing, I'll start off with my public health colleagues. We've been refreshing the SEND Joint Strategic Needs Assessment. It was published last year, and this is a refresh of the strategy. Really useful document, because obviously our SEND Joint Strategic Needs Assessment then informs our joint commissioning plans. So we're really pleased with that work that's going on. Within the delivery plan, we've also been working with health and social care partners and school partners around the co-design of our SEND joint commissioning strategy. That's a 3-year strategy, which is nearly coming to an end, I've got to say, in terms of its development. And work within the strategy is looking at how we can integrate better as a joint commissioning offer around our SEND community, but also how we can come together and develop better understanding of neurodiversity and what that means in Northants. I should say, whenever I say neurodiversity, I don't want our colleagues from our community of people with autism and ADHD to think that I don't mean them. So I mean a much more inclusive, wider offer around neurodiversity. So that strategy is starting to really formulate some really key priorities over the next few years that will be wrapped around our joint commissioning priorities. We've been working to develop our SEND sufficiency plan as a statement, and that is around our alternative placements, supporting our children to make sure actually we've got the right provision in place. We really do recognise that within our school communities there isn't always the right support offer depending on the complexity of need of the child. And whilst we're working to really drive forward an inclusive school offer, we accept that sometimes that doesn't always support the child, and actually we've got to work hard to make sure we've got sufficiency of service, and actually we've got alternative placements that can support that child and wrap around that child and the family. We've currently been working on our SEND and inclusion strategy, and that will go through the internal process at the moment. That really is just a refresh, because many of colleagues will know here that we already have a SEND and inclusion strategy. And the work to put in place our SEND and accountability and is it accountability and improvement board is now in place, and we've appointed an independent chair. And I'm really sad to say I forgot her name, but I know it's Fiona. Do you remember her name? Thank you. Lovely lady called Fiona, and I will get her name, who is our independent chair of our accountability board, but I'll provide you with that name. And what we thought we would do is, when our delivery plan comes to a conclusion over the next few weeks for the next Health and Wellbeing Board, Charisse has said that she'll bring with colleagues a wider detailed report on the outcome of that. So I hope that you just find that. I know it's a very light touch update, but I hope you found that informative.
Thank you very much. Prince.
Chair, just on that send and delivery plan, I think that's a very welcoming thing. I would like to see that detailed paper, hopefully, when it comes out. Also, on a more light touch note, there are families, especially within community of interest, that have struggled, when it comes to identifying their kids as, having special needs, and also whether that framework or the plan had actually taken that into consideration, and also how they can have easy access and work through that pathway to make sure that their children are also, included in that process. Thank you.
So, yeah, absolutely. By the way, it's been fundamental to the work that we're doing. So around our delivery plan and our programme of work, we have children, younger people and families wrapped around every plan. So they are an absolute voice in the work that we have been doing. And we've been collaborating with our parent carers in that plan. So I don't want anybody thinking that they haven't been a huge voice in the improvement plan, what we're doing. Yeah. Oh, sorry.
Just like David, having sat on the St. Both the last 18 months, we know the system has got some growing to do, and colleagues, in the ICB and others have worked really hard on thinking about what those pathways are like, making sure that where waiting lists are longer than we would want them to be for assessment, that families receive support during that time. Waiting well might be a way to describe it. But some of the breadth of what we're describing across, where we talk about the family hubs and the 0 to 11 and the SEND, is about how do we collectively support families to identify needs early and ensure that the right support's in place. I think you also mentioned education, health and care plans there, did you, Prince? And did you all plans more generally? You've talked about people accessing.
Yeah, so basically it's about people just, community of interest, some of the kids having that difficulty in defining their children as SEND. So in terms of the delivery plan, whether we have captured that as well and how that looks like.
Yeah, absolutely. Sorry, I didn't pick up on that point. So absolutely, the delivery plan it's not just about diagnosis, if you don't mind me saying that. It's about much more, providing really good information, advice, signposting very, very early, and working with our children, younger people and parent carers around what that looks like for them. I would say, though, what we have seen is fantastic work, and I don't think my colleagues will mind me mentioning, from our educational psychology and HC educational care planning team, and actually their performance to respond to the needs of children within the school community is really improved. It's they're doing an absolutely stunning job. But to answer that question, we're trying to work within the diagnosis, but also work with outside of the diagnosis. What do you need to help you as a mum or a dad with a child with needs that may be differently able, and what information, advice do you need? Does that make sense? Hope so. And then it's actually our independent chair is Fiona Phelps. That was very naughty of me not knowing, but there you go.
Yeah, there's a huge amount of resource being put into EHCPs and getting diagnosis and then dealing with that. So it's been very heartwarming to see that extra funding being put forward. So if that's the end of that item, we were supposed to have Sam Fitzgerald dealing with the Better Care Fund. Unfortunately, she's not very well, so David's going to take us through it. But just explain that, in case anyone doesn't know, that this Better Care Fund has been crucial in supporting people to live healthy, independent and dignified lives through joining up health, social care and housing services seamlessly around the person. And the vision is underpinned by two core objectives: to enable people to stay well, safe and independent at home for longer, and provide people with the right care, the right place at the right time. So that's sort of that in a nutshell. David, now take us through the detail. Thank you.
Thank you, Chair, and once again apologies from Sam for not being able to present this. She puts a huge amount of work into it, so it's not something that she would miss lightly in that sense. We bring 4 updates on the BCF to Health and Wellbeing Board each year, and one of them usually involves the planning for the next year. Ideally, it would be the same meeting every year, but unfortunately the guidance that comes out can be quite delayed. Last year it was quite delayed, this year it's been quite early, hence why we are bringing the 25-26 plan for approval by Health and Wellbeing Board today. Just for those of you who are not familiar with the Better Care Fund, it's probably been a pooled budget that's been running for about, well, since about 2013, 2014. So we're looking at 11, 12 years where this has been used as a methodology that sort of promotes greater integration between public bodies, but also with the voluntary sector as well. There are 4 main conditions for the Better Care Fund in 25-26. So we have to have a jointly agreed plan. This is one of the sign-off regimes within the local authority. We take the report to our executive as well. Similarly, the Integrated Care Board will do similar within their own organisation in order to take that forward. Implementing the objectives of the BCF, which focus around that shift from sickness to prevention and supporting people to live independently in their own homes and away from hospitals. Third condition is around complying with the grant conditions and the BCF funding conditions, including maintaining the NHS minimum contribution to adult social care. For those of you that are new to the Better Care Fund, there is a certain amount of money that gets routed to local government via the Integrated Care Board, and that has to be passported through in that sense. I've got Amy in the room today who's providing an annual update on Disabled Facilities Grant. But the Disabled Facilities Grant also makes up a significant proportion of the Better Care Fund as well. And the final condition is about complying with oversight and support processes. So naturally, with significant amounts of money being channeled through government and arm's length bodies, want to keep an eye and make sure that we're delivering on some of the key objectives associated with that. And they do that by monitoring some of those headline Better Care Fund metrics, which for the next year, would be no surprises to the majority of us that work in that space, but emergency admissions to hospital for people aged over 65 per 100,000 of population. The average length of discharge delay for all acute adult patients derived from 2 factors. So 1, the date where they are deemed to be ready for discharge, and 2, whether there is any delay between that date and the actual date where they're discharged. And then the final main metric is with regards to long-term admissions to residential care homes and nursing homes for people aged 65 and over per 100,000 population. There's also a focus over the next year on intermediate care capacity and demand plans, so making sure that there are jointly signed off plans that are really clear about the existing intermediate care capacity and any additional intermediate care capacity that we have within the system and how that will manage demand over the next year moving forward. There's 2 other papers attached to the cover report. So you have the narrative plan, which is the story, the words that sort of explain how we will deliver the Better Care Fund over the next year. And then you have the planning template, which is Appendix B within the document pack. That lists the 25 schemes that we've got within North Northamptonshire that the money which goes into the Better Care Fund gets allocated to. Largely speaking, they are the same schemes as last year, and that's partly because of the early publication of the planning guidance and the quick turnaround that we have been given in order to submit the plans for this year. There is an intention within the local health and care system to carry out a root and branch review of the better care schemes that we do have. It seems like every time that we go to do that, that something else comes along and sort of derails that a little bit for us. And recent announcements around NHS England probably will have an impact on us doing that again over the next year as well. And I must extend my support to my colleagues who are being affected by that in the health service as well, and anything that we can do as a local authority to ease that pressure and burden, we will certainly be looking at what we can do in that space. The one significant change that has been added into the planning template is that the local authority has agreed a one-off year funding to extend the Support North Northants scheme, which is circa £250,000 investment. We believe that it's something that should be invested in, but we do need a longer-term conversation across the system about how we fund some of these more preventative interventions moving forward. So I hope that I've done justice in the same way that Sam would have presented that, and happy to take any questions or comments from colleagues around the table. Thank you.
Thank you, David. The chart that shows all of the different projects is really interesting. It's quite small print, but it really shows the breadth of the facilities. And as you can see, the funding is split. Some of it's NHS, some of it's local authority, etc. So that gives a very good overview, as well as the sort of text, which is sort of more general. Oh, yes, sorry.
Thank you. Thanks, David. Support this submission. My only comment was your reference to some of the wider changes that are happening across the NHS potentially impacting on our review. I don't think it should. I think we should continue to do a review. We might just need to think about the partners that were involved in that review, because I think it is really important. As you know, things have often got in the way of that happening, but it is really important we do a root and branch review of are these the same thing, the right things now that they have been for the past few years. So we just support us continuing to do that, but perhaps thinking about a different way in which we can do it.
Thank you very much. We can shut that door. Yes, sorry, I was just distracted by the door being open and the noise.
Thank you. We cannot have a discussion about the Better Care Fund without my comment. That is a constant theme, which is a great missing of general practice as a part of these schemes and support for the winter to come.
Yeah. David, do you want to come back on that?
I think we have this discussion every year, don't we? And it's one of those things where, absolutely, I agree with you. The investment in primary care is hugely important moving forward. I think the challenge that we have around the Better Care Fund is that the grant conditions are very specific in how the funding should be spent, and there is more of a discussion around how central government and department should be lobbied around primary care investment moving forward.
Yeah, I think that's a topic for another place.
Absolutely. It's just a reminder when primary care reach capacity, you know where the patient go.
Yeah, thank you. Any other comments on anyone? Okay. Oh, no, I think he was just saying that Dr. Pogge was... Yeah. Yeah. Yes, so the board is asked on this particular one to approve the Better Care Fund schemes and performance template. Is everyone in agreement with that? Okay, no dissension. Okay, thank you very much. Right, the next item is over to the ICB, Health and Wellbeing Strategies section of Northamptonshire ICB's annual report and accounts. I think Karen is going to lead on this.
Yeah, thank you, Chair. So the ICB is required, as most organisations are, to produce our annual report and accounts, and we're in the process of doing that now. And the purpose of this paper is just to bring forward the content that will be included in around reference to the Health and Wellbeing Board and the Health and Wellbeing Strategy. Now, clearly, this is just the initial part. We need the full annual report to be brought here so that you can see this in context of the work that's been done. But I would like to just say that over the year, the past 12 months, different elements of the work that's been done across the ICB has been brought forward here. For example, the work through the 5-year plan, the urgent emergency care strategy, some of the work around primary care recovery and CYP and SEN. So they will all be included in the annual report. So just to kind of put that into context. We also have our 5-year plan refresh. So we do an annual refresh of our 5-year plan, which will come back here prior to being finalised. And that for this year is a light touch refresh because of the 10-year plan, which will be published later on in the summer, and we will be looking to work to respond to that. And I know we've had conversations here as well as in the Integrated Care Partnership about how we would do that collectively across the system. So just really, Chair, just to say this is a paper which just has a section of what would be in the annual report, and it's here to note and support the content and the wider report we brought forward once it's being drafted further.
Thank you very much. And I hopefully got some dates here that the draft version of the report will be submitted to NHS England. It's still there for a review on the 25th of April 2025, with a final version of the report to be submitted on the 23rd of June. Hopefully those dates will not slip, but we'll see. That remains to be seen. I think the board asked to review the proposed narrative and provide any comments or feedback. Secondly, if the board would like the ICB to bring back the final version of the report once it's gone through all the governance processes after September for completeness. Any comments on that, anyone? Do you think it would be best? Yes, sorry.
Me sitting this side of you is difficult, isn't it? In terms of the narrative, it's that piece in the paper, isn't it, that's about the health and wellbeing strategy. The only comment I would make is about maybe making it clearer in the Integrated Care Northamptonshire strategy that both of the health and wellbeing strategies align very closely to that, because otherwise it could look like we've got lots of strategies, but actually both have been written to directly align to that. That was just one comment.
Yeah, thank you. And likewise, the 5-year plan, I think that could be strengthened, that all three do that, don't they? So I can certainly feed that back. Thank you, Jane.
Any other comments on this? Or sorry. Oh, Prince, sorry.
That's all right, Chair.
It's a long way over there.
just a couple of things. Chair, you did mention that, and I just want to pick up on that quickly in terms of whether NHS England, and we are aware of it, in current situation, whether it will be still in existence, and because we know that is going to go away based on the current government's direction of travel. Would there be any impact in terms of the ICB and also the structures in terms of numbers and things like that? Would that have any impact? And also the dates that have been set, if anything should come earlier than that, what is the back strategy regarding that?
Certainly. So we'll continue to do the strategy as agreed and continue the annual report as agreed. Clearly, there's been some announcements last week around NHSE and also ICBs, but there's no further update or delivery model yet. So until we've got that, we can't comment further. But obviously, we continue with the planning as the dates are set. Yeah.
I think we just need to wait and see what comes out of that. So, yeah, thank you very much. So does the board think this would be a good idea to bring this back after in sort of September-ish, I think? Would that be all right, Karen, if we could do that? Yeah, thank you very much. Okay. Next item is Disabled Facilities Grant. And I've got Amy Plank and Alina Passari to present it. Thank you.
Thank you, Chair. This is an annual report I bring to the board each year, and this report is going to outline the spends and the allocation for disabled facilities grants for the last financial year, 23-24. Disabled facilities grants, for those that don't know it, as outlined in the report, are a mandatory grants that we provide for residents across North Northamptonshire that are eligible, that have a disability, and we provide a number of adaptations, which is outlined in the background of this report and how we go about doing that. So I won't go into detail with that unless you require me to. The spend for 23-24 was just over 2.3 million, which has increased from the previous financial year, which was just over 1.8 million. The last financial year we were allocated just over 2.5 million. We still had some money in the reserves from previous years, but we also had a number of legacy cases in the backlog, which we've now near enough cleared. So the remaining budget as of the end of last financial year was just over 3.4 million, and that's explained in the box under 6.1 of the reports. There have been a number of issues and challenges over the last couple of years, many of which we've overcome, which I've outlined in section 5 of my report. We were dealing with, as I said, a number of backlog cases, both from the legacy councils and also from occupational therapy as well, but we're now in a really healthy position now where we're largely dealing with cases as they're coming through the front door now. In any one average month, we're roughly completing about 18 to 20 DFGs a month. We're seeing about 22 new occupational therapy referrals coming in each month. And on average, the occupational therapy department assessed 295 cases. There have been some challenges around suppliers and contractors, which I've talked about over the previous years, and we're now looking at putting in place a new framework with foundations to get contractors and new contractors onto the installers network. And we're also, obviously, we've just finished the permanent restructure for private sector housing, and we're increasing resources to meet demand, so we will be having more resources to tackle the demand as well, because demand remains high for this service. And there are no significant legal implications with regards to this service, and there is no significant risk, really. We continue to receive the allocation each year, which has increased each year. So the recommendation would be to ask the board to note the spend for the financial year 23-24, and just to note that it is a statutory requirement that we do provide these DFG grants. Thank you. I'm happy to take any questions or comments.
Thank you very much. Any comments from anyone? I'd just like to point out that on page 143 it mentions that there was approval by the executive on the 16th of January for some changes, quite extensive changes to make life easier for applicants. So you know, that's not in detail here, but it's all in detail in the executive report if anyone would like to have a look at that. Lots of, you know, quite extensive changes, really. Yeah, Patsy.
Yeah, I'd just like to ask a question, and it might be, like you say, in the executive report. But in terms of people applying for this grant, do you have a breakdown of who they are? Or are they referred through the OTs, or do people... Yeah, I suppose they are referred through OTs, but do you have a breakdown of the kind of who they are, where they are, locations where they live, the demographics, those kind of things?
I do. I don't have that to hand, unfortunately, today. But obviously, each year we're expected to reply for Delta. We do a Delta return each year, which gives a breakdown of the age group and where the addresses come from. So we do provide that each year to central government of the number of DFGs we've provided, by the age group, by the amount they cost. So I do have that data, yes. Yeah. Not to hand, though, unfortunately.
No,
I wasn't expecting to be asked that, but I do have that. And obviously your point on the policy as well, yes, I've not touched on that because it was only approved at executive in January and we've only just implemented, so I've got no sort of success stories to tell from that, but it does certainly widen the scope of what adaptations we can provide, and it's provided a lot of mechanisms to allow residents to access funding quickly and more efficiently. So I'm hoping when I come to this board in 12 months' time, I'll be able to update on the new policy, and I can come back and give you a breakdown of the demographics, or before if you'd like it.
Yeah, or just tell us where the links are so we can find that information. That'd be helpful. Thank you.
it'd be useful to see the sort of effect of those changes, and if it's widened the scope of people that are able to get the disability grants, because obviously this really helps people stay in their own home, which is the whole ethos of adult social care that David and I discuss at length. Always trying to keep people at home.
Yes,
so
exactly that, keeping people out of care and out of hospitals.
Yeah, yes, and they have enough pressure. Okay, Prince, yeah.
Yeah, Chair, just a quick one. In terms of, again, the announcement that came out from government recently, it's about disability allowance as well going to be impacted in some ways. Because they are looking at restructuring that and those who actually fall into that. I guess my question is, would that impact on the funds that you are being allocated, and whether that would, have any significant impact on it, and if yes or no, and if
of
yes.
The restructure, did you say? Did you talk the restructure, the private sector housing restructure?
Yes, because the government wants to kind of, reduce the number of people who are actually entitled for some of these disability allowances.
There'll be no significant impact, no. I mean, obviously the allocation has increased year on year and the number of resources hasn't really increased. It has increased slightly this year, but because demand is high and we're paying an element of the funding towards the COT services as well, because we have an underspend each year, I don't envisage a problem with lack of funding at all, no. And what I've said when I went to the executive in January is if funds start to dry up, should I say, then we will do less discretionary grants, because the priority is mandatory grants. So the new policy allows for more discretionary grants around dementia and MND, etc. So should we be in a position where we're unable to meet those demands with discretionary grants, we'll just have to slow that down, because the condition of discretionary grants is only if there's enough funding available, because the priority is the mandatory grants.
I think the main concern here is not having the money, it's actually getting the suppliers and making sure they can actually fulfil the work, because even if you've got agreement, if you haven't got the people who can do the job, then that it won't get done. So that's probably the priority at the moment, isn't it?
Absolutely, yes.
Yeah. Okay. Thank you very much. So is the board happy to note the Disabled Facilities Grant spend? So it's several ones come today that are sort of statutory jobs of the Health and Wellbeing Board, and that's one of them. Okay. Next item is the Combating Drugs Partnership update, which I know is close to Jane's heart, and if I can ask her to present it.
Thank you, Councillor Mercer. And I will try and not wax lyrical too much about this, colleagues, because you probably looked at how many slides there were and thought, oh dear, we're going to be here until the end of the week. But it is a really fantastic functional partnership. And what I'll do is I'll pick a few particular slides for us to have a look at. The first thing I wanted to mention is, so myself and Sally Burns from West are the SROs for this particular piece of work. It came out of the drug strategy From Harm to Hope in 2021, and we have changed the title of our partnership slightly, in that we thought it was slightly light on alcohol, and so we actually call it the Combating Drugs and Alcohol Partnership, and that's really just in recognition of the incredible harms that we see in terms of alcohol across lots of the parts of the system. I think policing colleagues, for example, will absolutely recognise the issues that they see around alcohol. We see it in terms of hospital admissions in every single part of the system, really. So the CDP is a cross-agency, cross-organisational, cross-county partnership, and it has an incredibly wide membership and a very active membership, and I think that's going to be really obvious in some of the particular slides I'll pull out. But if we think about who's there, I think what it's really particularly good at is we have a really strong membership and leadership from Northamptonshire Police, from Fire. We also have some very specific pieces of work being led by NHFT. We have the ICB. We have a whole range of different organisations there. And also we are also very much reliant on the voice of people with lived experience as well. So there's a huge amount of work that goes on across the partnership. The Harm to Hope strategy has three major areas that we've been asked to focus on. So breaking drug supply chains, delivery of a world-class treatment system, and generational shift in demand for drugs. So the breaking supply part is rather unsurprisingly led by our policing colleagues in Northamptonshire, and they've done some fantastic work in that area. The world-class treatment bit is led by public health, working with our lots of different partners, particularly our substance use providers, but also with our acutes and other members of our health system. And then community safety cover the shift towards demand in drugs. So what I didn't want to do is go through every single detail on these slides, because there are plenty, is the best way to describe it. But I wanted to just pull up some particular slides. So either we can do this on the screen, or people can also look at their packs. So the first is on page 156. So I won't go through everything, because we literally will be here all day. But I wanted just to bring attention to the programme structure, which is page 156 of our packs. And that particular schematic, if you like, lays out really what we do as a function, but also who's involved in that. So you'll see when it comes to treatment and recovery, we have 3 particular subgroups of that. So one of those is around criminal justice pathways. It's really important that we get that right. So when we have people going into prison estate, for example, it's really important that when they come out of that, that they are coming out to a drug offer, or an alcohol offer, or some sort of support offer, which means they stay on the route that they may have finally got to in that secure estate. And there's been some really fantastic work, cross-organisational work going on there to make sure that pathway is right. We have a health and care pathway group, but I wanted to focus also on the co-occurring conditions pathway group. So lots of people here will not be surprised at all that a significant proportion of people with a significant drug and alcohol issue, or drug or alcohol issue, will also have a significant mental health issue as well. And people also won't be surprised that there has been a narrative, I guess, but also evidence of this nationally for a number of years, that sometimes people may feel that they're not accepted in mental health services because they've got a substance use problem, or they might feel it's difficult to access substance misuse services because they've got a mental health problem. Now, I think that is changing significantly, and I've been involved in this area of work for a few years now, and I think we've made massive progress actually on that. But locally, there's been a really big push on that, and some really fantastic cross-working between our substance use providers and also our mental health services, largely through NHFT. The other thing just to pull out on there's a couple of enabling work streams, which I just want to quickly explain. So experts by experience are pivotal to everything we do, and they lead really important areas of our work, and they will tell us if we think they've got it wrong, and they are fantastically supported by our drug support services locally to have that voice. We've also got a really important programme called ELDIS, which is around data intelligence and information sharing around deaths, but also around near misses to do with drugs particularly, actually. So lots of people in this room will know that we're all very worried about some things that can be circulating that are very dangerous, and that's particularly synthetic opioids. I'm thinking about things that you might recognise as fentanyl, but they have a range of different names. Now, the ELDIS group does a huge amount of work, and the amount of partners involved in this, and I'm looking at Helene because Helene leads a lot of that work, is incredible. And the amount of information that goes out when we do have either deaths or near misses, and people share that information to keep people safe, that is really, really important. We also have a really strong data intelligence platform and work that we use that's from Laura. So we've got lots of our partners within the policing area, for example, putting data together to give us a really good picture of where we are and where we need to be. So we have these different streams that underpin it, but ultimately it's about saying in these particular areas, in a nutshell, how do we make sure that that drugs aren't an attractive, and drugs and alcohol aren't an attractive pathway for people? How can we get a shift in that? But if people do go down that road and need help, is it there? Can we actually provide that in the best way for everybody in our communities so it's accessible and they get the right outcome from that? And that is a long-term outcome. We completely understand that sometimes people come round the treatment cycle, if you like, more than once, but we need to make sure it's the right offer for people. Some people want a recovery-based programme, some people need structured treatment. Whatever that is, it's absolutely got to be right, which is why we need so many partners collectively working on that. So 158 is in your pack, shows our 6 critical Northamptonshire priorities. And just I'll pull a few a few out of them. So one of the things that we've really done is trying to get more people into treatment, and that's working really well. So all of our treatment providers across Northamptonshire have done a really good job in accessing people who need support, giving them the right support and getting them into treatment. We're seeing more referrals come from a whole range of different providers as well, and I think this partnership actually influences that really heavily, I think, as a success in its own right. I've mentioned co-occurring conditions, so what used to be called dual diagnosis in old money, but also I wanted to focus on understanding the needs of alcohol only as well a little bit more. So some of you may be aware, and I know partners from all the organisations represented here came to an alcohol summit that we held in January. So that's about kicking off for the Crime, Drugs and Alcohol Partnership, Combating Drugs and Alcohol Partnership, a whole new work stream around alcohol-related harm. So what we need to be able to do is ensure that people understand they've got an issue with alcohol. We still have lots of people with a very significant alcohol problem who don't know they've got an alcohol problem, that our services are right for people with an alcohol problem, and also that we're lobbying at national level, for example, around some of the things that we could be doing differently to reduce the harms of alcohol. So I'm now going to move you to 173. As I said, I don't want to go through all of these because we will be here all day, and also I'm very tempted to talk about it for several hours, which Helen is nodding at because she knows what I'm like. If we just move on to 173. So this is showing about adults, showing the numbers in adults in structured treatment. And the reason why I wanted to show that is I wanted to show really where we've been and where we are and where we're going. So all absolute congratulations and kudos to our services who are getting more and more people through the door. And this is really, really important. I mean, we look at how many people are in structured treatment now. That number, we anticipate that to keep going up, and that's really, really important. Where our bigger challenge is with alcohol. So what we want to do is make sure we get what's called the penetrance rate. So what that means is alcohol services tend to have a penetrance of about 20%, which means 20% of people who've got the capacity to benefit from an alcohol service actually access it. That means there's 80% who aren't. So we really do need to do some work around that to try and get figures up in that area. It's very difficult with alcohol because we are so culturally aligned to thinking it's okay to drink quite excessively, and we also know that there's a very significant issue with it being hidden in some communities and also particularly in some age groups. So we've got a huge amount of work that we need to do in that area. I'm just going to move on to page 183 in your packs. So what's new for 2025? So we've done a huge amount already, and I think I love going to these meetings. I'm the chair of the Combating Drugs and Alcohol Partnership. I'm also the chair of the Community Safety Partnership for Northants, and I see a lot of read across in those two particular groups. But there's things that have been achieved, but we're also now at the point of saying, well, what else do we need to do? And I think there's some really good things on this slide for us to think about. We want to make sure that we are doing better than we said we even thought we might be able to be. So we want to exceed those ambitious targets that we've laid out around numbers in treatment, and we're certainly on the right road for that. I've mentioned the Tackling Alcohol-Related Harm programme. To me, that's really pivotal. I was quite surprised moving into this system to not see a big worked-up programme actually about reducing alcohol harm, because it is such a wide-ranging issue that hits so many parts of the system. But actually we're getting there, and we've got really fantastic buy-in from our partners in that. We've got recommissioning, so people will know that the drug and alcohol services, well, you might not know, but you should know, I'll tell you now, are going to be recommissioned in 2026. So that means we've got a piece of work going on now that's a really in-depth piece of work to say what is the offer going to be post-2026 to make sure we get even more people into treatment and even more people successfully completing treatment. The co-occurring pathways policy for children and young people. So we've done some fantastic work locally around adults, and I've been really impressed with the willingness of different partners to work together. It's been fantastic, but we need to make sure that's the same for young people, for children and young people. And I think nationally, my understanding is there is less work in this area, so we're probably doing something here that's a little bit different, and hopefully we can help other areas develop something similar. We're trying to do things that are a bit different now. TikTok platform, I don't even have TikTok. Helen used the phrase people of a certain age. Now that's me. It's not a TikTok person, but I have to understand that other people are. So we're trying to make sure that we're accessible as possible. Experts by experience, we want to make sure that we have the best possible experience for our experts by experience in terms of them informing the programme, but also that we're listening to them and we're shaping the programme around their particular experiences, what they think or know will work, because that is absolutely essential for us getting the right focus. We've got a local film about breaking the chains of addiction. And also, we've got a new piece of work around family drug and alcohol courts in Northamptonshire. So there's lots of things that we're focusing on for the next year. And then that final slide talks about some of what we're calling game changers. Now, a couple of things I'd like to mention here. So we have got Buvidal use. So for people who don't know what Buvidal is, it's a kind of an alternative to methadone. It's got lots of particular strengths Buvidal has. It's a different kind of drug. We know that the early evidence for that is really positive, so we want to really build on that. Our local drug and information system, we're going to enhance that. I personally think it's extremely functional. I've worked across other areas with these, and I think our local one is incredibly responsive, but we also want to make sure we build on that going forward. Co-occurring mental health or dual diagnosis pathways, we need to make sure they're embedded, evaluated, but also we're starting to get that learning into the children and young people's space. So introduction of drug testing on arrest. So I don't know whether any of our policing colleagues want to say anything about that. Whilst we're talking about policing as well, I just wanted to point out that Northamptonshire Police were one of the first, I think, police forces to use naloxone, and they've already saved lives using that. So if anyone doesn't know what naloxone is, it's something that you can very easily administer to somebody. Actually now it's intranasally, which can basically bring people around when they've stopped breathing, when they've had an overdose of something like heroin. And the police have been a fantastic partner in that, and it's saving lives already. So I think that's another strength of the partnership, is that willingness to try different things. The Alcohol Harm Conference is turning into an action plan for what we need to do best. I'm a great believer, do 3 to 5 things really well. So we'll pick a few things that we do really well as a system around alcohol to make the difference. And then the final one is about getting our commissioning right. If we listen to the voice of people with lived experience, if we listen to our stakeholders, if we build on what evidence there is out there for the best possible practice, we will get a really good offer for our local population, building on the fantastic offer we've already got from our incredibly dedicated set of drug and alcohol providers. So that's all I wanted to say. I hope I haven't gone on too long, Chair, but willing to take questions.
No, as you can tell, Jane's very passionate about this, and I think explains it so clearly as well. And there is a fantastic amount of work going on in this area. I went to the Alcohol Harm Reduction Conference, and it was quite moving. The effect of alcohol, it's not something that I was personally aware of, and it certainly opened my eyes. So any comments, observations or anything from anybody? Prince?
Just a quick one, Chair. This is just a testament to what Jen has just said, because we conducted a research, on drug and alcohol usage, and one gentleman we met, I mean, his story was very, very moving, and to say that is a list. I think he will be the best person to be here to kind of share that testimony as to what impact, drinking had on him and his life, and how he nearly died. The experience that he shared with us was just unbelievable. Initially, he didn't want to share, but at a point he said, "I'm ready. You can record it, and I want everybody to hear this." And so I think this is very, very important. We are losing a lot of people to this kind of drug, and whatever we could do to kind of mitigate that, I think it's in the right direction, and I'm all for that. So thanks.
Thank you. At this conference, there are several people that are going through similar and explain their circumstances and their journey, and that really brought it home rather than just talking about it as professionals. So, okay. Jane, did you want to finish off, or you?
just to say, I was meant to hand over the chair of the Combating Drugs and Alcohol Partnership, but I'm now staying as chair of the Combating Drugs and Alcohol Partnership. So what I'll do, Chair, is I'll bring another update later on in the year, particularly maybe if people are interested in a particular piece of work that we're doing, to give some maybe examples. Also, we do have incredible people with lived experience involved in this work, and so if people would be interested in hearing some of that experience as well at this board, very willing to engage in that.
Thank you very much. Well, thank you very much, everyone. The board's asked to note the progress of the Combating Drug Partnership against the strategic outcomes and priorities to 2025. Everyone happy to note that. And in that case, I will close the meeting as that is the end of the business. And as this is the last session or last meeting of this term of the council, I don't know if I shall be here in future, but if I am, then I will see you then. But there's something called elections coming up, so okay. Thank you very much.